evening. Thank you for joining us. My name is Clarice Redding Lewis, Chief Recovery Community Officer at Hanley Foundation, where our mission is to eliminate addiction through prevention, advocacy, and recovery support. Tonight, I would like to welcome you to the Recovery Leadership Institute at Hanley Foundation's first ever Summer Recovery Leadership Training Session. Tonight, you will join us to witness a collaborative effort between Hanley Foundation, Palm Beach County's Community Services Department, and hosted live from the Palm Beach County Hub. We would like to take a moment just to alert you that there will be a Q&A session following tonight's presentation, so be sure to leave all questions in the chat. I would like to take time to acknowledge tonight's guest speaker and trainer, Mr. Donald McDonald. Mr. McDonald has been thriving in recovery from severe mental and substance use disorder since 2004. Previously, Donald served as the National Field Director of Faces and Voices of Recovery, the Executive Director of Addiction Professionals of North Carolina, and Director of Advocacy and Education at Recovery Communities of North Carolina. Donald is currently the Chief Recovery Officer with All Sober, a startup public benefit corporation that is creating a comprehensive online recovery ecosystem due to launch this fall. He has written and presented extensively on recovery, addressing stigma and the intersection of harm reduction and recovery. Mr. McDonald is a licensed clinical addiction specialist and recovery coach professional and holds a Master of Social Work from UNC Chapel Hill. Please join me in welcoming Mr. Donald McDonald.
Thank you so much. I appreciate it. Wow. You have to be here to know what's going on. These are exciting times. Thank you very much, Hanley Foundation Board of Directors. Thank you, Jan. Thank you, Clarice, for hosting me down here. I like to holler into microphones as often as I can to promote recovery-oriented systems of care, to address the stigma surrounding people who use drugs and people experiencing substance use disorder, to dismantle discriminatory barriers to the help and freedom and wellness that people and their families deserve. And props to Hanley Foundation for taking part in this initiative. Let me see. There's my slides. Am I advancing the slides? For whatever. Yep, that's great. Hi, I'm Donald McDonald. I'm a person thriving in sustained recovery from severe mental and substance use disorders since 2004. And what that means is I haven't been alone in nearly 17 years. I haven't been incarcerated. I haven't been hospitalized. I haven't been a burden to society in nearly 17 years. I haven't had to use alcohol or other drugs or other behaviors to help face the day in 17 years. I have the resources, both internal and external, not only to be well, but to be better than well. 17 years ago, nearly 17 years ago, I was in detox. I was feeling hopeless. I was feeling helpless. I was wanting to end my life. And fortunately, and I'm going to tell you a little bit more about that, how that happened, I got the help that I needed, then I got the support that I needed, and then I got the life that I deserve. And this is all part of recovery-oriented systems of care. This is all part of addressing stigma and removing discriminatory barriers to freedom and wellness. I have to give a shout out to, are those the public-facing slides? Oh, you need to go back. I'm sorry. Yeah, nope. There we go. One more forward. Cool. Now I know where the slides are. Awesome. Great. Yeah, so this is okay. This is, you know what? This is recovery. This is reality. I work with a company called All Sober. This was born out of the experience of two family members who tried to get a loved one into recovery and struggled with the siloed and diffuse system that you don't know where to turn, you don't know what to Google, you don't know who to trust. And these folks went home and they sketched out on their table what they believe that they as a family deserve. What they deserve, and that's what we're creating. We're creating a comprehensive recovery ecosystem on the web. And I'm excited. Check us out at allsober.com. Check us out on social media. And hopefully this fall, we'll be launching a good bit of our site. And by January, we'll have a full launch. So, some audience participation. We've got a lovely audience here. Recovery. Before we move forward on promoting recovery-oriented systems of care, before we move forward on trying to increase access to treatment and recovery support services, we may have to come together to agree on what recovery is. Maybe. What is recovery? Anybody. There's no wrong answer, which is kind of the secret. What is recovery? It is individualized.
Making your way back to health.
Making your way back to health. Nice. Anything else? What is recovery? Keep it simple. Sobriety. And whatever that means, sobriety. In my recovery pathway, it means that I don't use alcohol and other drugs. And for my personal definition of recovery, that is evidence that I have achieved some degree of wellness and some degree of better than wellness. But I don't impose that on everyone. But for me, that's a thing. Anything else? Well, it shouldn't surprise you to know that not everybody agrees on what recovery is. They don't. There are a number of official definitions, unofficial definitions, and I'm going to share a few with you tonight. So I like to start with 12-step, because 12-step communities of recovery have shouldered the burden of continuing care in our communities for nearly 9 decades now. And because of that, the 12-step lens on recovery underpins much of our health and justice policy and practice. It just happened that way. It informs a lot of the treatment, it informs a lot of drug policy, it informs a lot of criminal justice policy. The 12-step definition of recovery, and this is not an official definition of recovery, this is based upon my some 3 decades of experience of being a member of this culture, being a member of this community, of going to mutual aid meetings with these individuals for 3 decades across the entire world as I traveled the world in the Navy, reading every piece of literature that has been written from this community and coming to my definition. And then when I came to my definition, I reached out to my peers on social media and I said, what you think? And naturally, some people got a little upset, and I don't know everything. So it was refined, and it was refined based upon my consultation with that community, the diverse members of that community. And it starts with abstaining from alcohol, other drugs, and non-prescribed medications. And you notice I have some caveats there. They're in Narcotics Anonymous. If you're taking opioid agonist medications to treat opioid use disorder, within that culture, and this is their choice, you may not be considered doing the deal or in recovery or clean, as they use the term in that community. Additionally, it has to be pointed out that this is not to be confused with the tradition, the third tradition for becoming a member of this community. Everyone's welcome to come get them some. The only requirement for membership is a desire to stop using alcohol, other drugs, mind-altering, mood-altering substances, but to have in this community what is a measurable degree of recovery. The medications can play an issue. Attending mutual aid meetings. Now, these are the gatherings of these individuals, whether you do it daily or once a week, but part of, are you in recovery? Are you really in recovery? Are you doing the deal? Has to do with attendance at these meetings. And then getting sponsorship, providing sponsorship, doing 12 steps, embracing those principles in all aspects of your life. And if you're slightly more daring, having a spiritual awakening as a result of these. This is pretty awesome stuff. This is a culture, a splendid 9 decades old culture of individuals who were experiencing hopelessness associated with alcohol and other drugs. And now, if they adhere to that pathway, they have achieved a state of wellness that is transcendent, that is a spiritual awakening as a result of it. And then they are called upon to go out and witness to others, to share what they got, okay? Now, does this sound like something that underpins public health policy or justice practice? I would say no. I would say it's a beautiful culture. It is a culture from which I am a part. These are my people. I'm excited to tell you that we have a definition of recovery from SAMHSA, and it's one that the Hanley Foundation is embracing in their recovery-oriented systems of care model. From SAMHSA, a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. So it's a process, not an event. It is a process of improved health and wellness. And I'm excited to see a government agency throw in such concepts as self-efficacy and self-actualization there at the end. Strive to reach our full potential, but not reaching your full potential, but striving to become fully a citizen by your definition. And I really dig that definition of recovery. It resonates with me in my recovery from mental and substance use disorders. And when I became a provider of services, it was particularly helpful for me in having reasonable expectations for my participants. So I encourage you to embrace SAMHSA's definition of recovery as well. Next slide. It's important for us to understand that this is not just something that happens by chance. Okay, and SAMHSA took another step forward and said, there are dimensions of wellness that we need to help address that will help promote this pathway of improved health and wellness, addressing such things as housing, having a safe and stable place to live, having a safe and stable place to live. Remember, we're talking about ROSC. Health, learning to overcome, manage, or more successfully live with symptoms, making health choices that support one's physical or emotional well-being. Purpose, engaging in meaningful daily activities. I'm talking about volunteering. I'm talking about parenting, time with your kids. I'm talking about going back to school. I'm talking about going to work. Purposeful daily activities. A safe place to live, purposeful daily activities, a process of addressing your health, and then here's the big one, community. And we've learned a lot. You know, Johann Hari came out with this TED Talk. Everything we know about addiction is wrong. The opposite of addiction is not particularly sobriety or abstinence, it's connection with other human beings. And this is based upon research that Bruce Alexander did. Much of the understanding that we have of addiction was based upon rats that were tortured inside little boxes. And naturally, they had a propensity to become addicted to drugs versus the nightmare in which they were living, a nightmare of isolation, a nightmare of lack of purpose, a nightmare of diminishing health. And so he went about throwing them in a splendid cage, rat park. Lots of stuff to do, lots of other rats to hang out with, because rats are like us, they're social beings. And what he discovered is these folks did not have these rats, rather, I'm anthropomorphizing the rats. The rats did not have such a propensity to engage in the drug use. They would rather have water and hang out with their friends and play with their toys. And this is the disconnection theoretical model of substance use disorder. So community cannot be overstated. Our connection with other human beings cannot be overstated in its importance. And this all informs the ROSC model as well. The thing about, we're sitting here in a recovery community center that I'm going to be talking about here in a minute. This is the hub. It's pretty awesome, Ian. You're doing a very good job here. I'm excited to talk to you more about it. But this is a place that embraces many pathways of recovery. In the website, in the description of the hub, this is not a 12-step clubhouse. 12-step clubhouses are awesome. I've been to lots of meetings in 12-step clubhouses and dances and banquets, and it's been awesome. But this is a single pathway of recovery for individuals. A recovery community center is a convening place for the ecumenical culture of recovery, the many pathways coming together. I'm going to talk a little bit more about that in a minute. But actually, this previous slide is something that our friends at Unity Recovery Community Organization in Philadelphia threw together, Robert Ashford and his crew, outlining the different categories of mutual aid, of which 12-step is one. 12-step is one. There are other pathways, whether one wants, they have strong Christian convictions. You got your people. Come get your people. There are non-secular pathways, non-secular mutual aid. You want nothing to do with God or a higher power? Well, that's your right as a human citizen not to have to make your people ones that don't align with your belief system. So there's secular pathways of recovery as well. They're not as robust as 12-step. 12-step is always in your community. Come get you some. But look for alternative mutual aid meetings. If 12-step's not working for you, go to a recovery community center and learn more about it. I know that this particular recovery community center is embracing SMART as an option for folks. And SMART, S-M-A-R-T, check that out as a pathway of recovery as well. All right. Here's the American Society of Addiction Medicine. And this was super exciting for me. I don't know if everyone else got excited about it as I did. But in 2018, they came out with their strategic vision for recovery, or rather, see, I threw it out there, their strategic vision for themselves, addiction medicine, where previously it was prevention, treatment, and remission. Remission. And this fails to acknowledge the chronic nature of substance use disorder, the complex needs of people who recover from addiction. They added recovery to this vision, embracing the full spectrum of experience, prevention, treatment, remission, and then lifelong recovery. And this affirmed what many of us already knew, that recovery means so much more than the absence of alcohol or other drugs from an otherwise unchanged life. And then it means something else, and then it means something else, and then it means something else. I'm sitting here pushing 17 years in recovery, and it means something very, very different than when I was 2 years into recovery. I still have needs for community, for health, for home, for purpose, and I still can help provide those needs for other folks. So recovery is a lifelong process, and recovery is part of the addiction medicine vision to be addressed with relationships with providers and with your community. Okay, so we're going to talk about recovery-oriented systems of care a little bit now, and we're going to talk about recovery management, but we have to talk about the opposite of what that is first. Do you think that addiction is a chronic illness? And why should it be considered a chronic illness? What are some other chronic illnesses? Cancer. Asthma. I take a maintenance medication, particularly coming to a new environment over this weekend down here in Florida. I've been using my maintenance medication. Asthma, high blood pressure. I took my lisinopril this morning. Diabetes. Depression. Okay, what about addiction? Should it be considered a chronic illness like those? Well, folks in this room are nodding, yeah, because it kind of makes sense. But you know, it's all folly until we actually have some kind of academic standard, some measurable protocol in place for why it's a chronic illness. Fortunately, researchers have done that for us. McClellan and others compared alcohol use disorder to asthma, high blood pressure, and diabetes based upon certain measurable and observable criteria. First of all, the cause. Controllable risk factors. Well, just don't drink. Well, just don't do drugs. There are also controllable risk factors for asthma, high blood pressure, and diabetes. I have environmental factors that I could control for both my asthma and my high blood pressure. There are behaviors that I ought to be engaged in to help reduce the incidence of relapse in those conditions. I don't always do it, though. Uncontrollable risk factors. Well, you know, no one chooses to have asthma. Well, we discovered with alcohol use disorder that there are uncontrollable risk factors as well, whether it is the 50% estimated genetic influence or the trauma that you have experienced or co-occurring mental disorders. Estimated genetic influence, once again, strikingly similar across the board. Strikingly similar across the board. A wonderful graphic there. So next is, it fits like a glove, right? It fits like a glove, but does it act like a glove? So in the next bit of comparison that they did, well, there's no cure. Or is there a cure? There's a cure for addiction, isn't there? No. No, for alcohol use disorder, just like asthma, diabetes, and high blood pressure, there is no cure. That's the nature of chronic illness. There are therapeutics, there are behaviors, there are medications that you can engage in that will reduce you to a subclinical presentation where you no longer have the symptoms of this disorder. But is it gone? No. So same with alcohol use disorder. Clear diagnostic criteria. And I like to drive this one home. When you take your young'un into the doctor's office and you suspect that there might be asthma, it's not guesswork. And there's nothing mystical or arcane about it. And there isn't, well, your kid doesn't have asthma unless they're ready to admit that they have the asthma. There is clear diagnostic criteria by professional clinicians to diagnose an individual with asthma and high blood pressure and diabetes. And that is also the case for substance use disorder. The Diagnostic and Statistical Manual for Mental Health Disorders, version 5. As a clinician, I crack that open, get a robust history from individuals, and whether they're ready to hear it or not, I am in a position of diagnosing a substance use disorder and recommending a treatment for folks. Unfortunately, in the addiction space, though, we have left some of this to chance. It becomes arcane and ethereal, and then there's this business of whether you accept it or not. And this is curious business, and I will contend that it's likely due to the moral theoretical model of substance use disorder. Even though in this, it is strikingly proven that it is incredibly similar to other chronic illnesses. And patient and family psychoeducation. And this final one here. Well, if you tell a person that they've got the diabetes, right, Wilford Brimley, they got the diabetes, and if they don't take their medication, they're going to lose a limb. If they tell me, Donald, if you don't take your lisinopril every day, you're going to have a stroke, and your wife's going to have to change your diapers, then I'm going to make a choice, right? No. But those people with addiction, you tell them what's going on with them, you tell them what's happening, and they just never listen. They don't adhere to their recovery management protocols. They always experience relapse or recurrence or return of symptoms. And I'm excited to show you that this particular data set shows, once again, an average of 30% to 50% of folks with all of these chronic illnesses, they don't follow recovery management protocol. That's just part of being, a very flawed human being. And my wife is a medical professional, and she was quick to tell me that this is true for all chronic illnesses. Folks just don't maintain their recovery from chronic illnesses as they ought to. And then this last one, the recurrence of symptoms, or what we might consider a relapse for addiction or for other chronic illnesses, is the same, strikingly similar, once again, around 50%. So this academically shows you that addiction is not just we think it's a chronic illness. It quacks like a duck, it walks like a duck, it's a duck. Let's talk about ROSC. So if we've been responding to addiction, which is a chronic illness, which most agree is defined by the compulsive seeking and or use of substances in spite of consequences. If we've been responding to it with consequences, with incarceration, or we've been responding to it with the acute care model of addiction treatment, which is a quick cure, and it hasn't been working, ought we be surprised? Ought we be surprised? And is there a better way? And there is a better way. And Hanley Foundation and Florida as a whole is actually embracing this readily. They're one of the leaders in the nation, in my opinion, in turning this theoretical construct into something that's actually implementable in programming and in funding. And so I have a very complicated definition here. It's actually a pretty accessible definition from the Florida website, okay? And it's good stuff. And for y'all here, it's a value-driven framework to guide transformation of a behavioral health system of care. The framework structures behavioral health systems to involve a network of clinical, non-clinical, and supports that sustain long-term community-based recovery, because we don't get well in treatment, we get well in our community. Formal and informal service networks are developed and mobilized to sustain long-term recovery for individuals and families impacted by behavioral health disorders. ROSC reflects variations in each community's vision, institutions, resources, and priorities. The system is not a treatment center, not an agency, but it's a macro-level organization of all the resources that exist within a community or a city or a state or a nation. Recovery-oriented systems of care is the ultimate de-siloing of everything that an individual and a family member may need to sustain recovery, to get well, to get better than well, and then to thrive in recovery, to come get them some. As I said, it's more than just the absence of alcohol and drugs from an unchanged life. It's more than a veil of tears. It's more than trudging. Recovery is awesome. Come on. ROSC promotes good quality of life, community health and wellness for all, prevents the development of behavioral health conditions. So we're meeting people earlier in this process. We intervene early in the progression of illness. We don't wait for this rock bottom business to help folks and to stop the progression of illness. We reduce the harm caused by substance use disorders and mental health conditions on individuals, families, and communities. And this is the big one, we provide the resources to assist people with behavioral health conditions to achieve and sustain their wellness and build meaningful lives for themselves and for their community. What does that mean? That was a lot of words, and I read it out loud for you because I think it's pretty splendidly written by Florida. And they've written it into their funding opportunities as well. So they're actually expecting folks to consider ROSC in the implementation of their programming. And I'm really excited about that. And I'd love to see all states do that. So I have a video now that we will not play. I was going to play, but I'll go ahead and invite you to come to my YouTube channel, Donald McDonald. I don't really remember the address to it, but Google me, Donald McDonald Recovery. You'll find my YouTube channel. And on this channel is a brief 3-minute clip by a splendid human being named Bill White. This fellow was a clinician in the early 60s, become researcher to help transform systems into a recovery orientation, become recovery movement leader with his research and with his writings and with his speech. And in this particular clip, during a ROSC presentation of a good number of years ago, because this is not a new concept, he says the acute care model of addiction treatment is politically, culturally, scientifically unsustainable, untenable, inexcusable with what we know about addiction as a chronic illness. If we are putting people in brief events, treatment events, or no treatment at all, and expecting them to recover, or yet to thrive in recovery, well, that's just insane. We're setting them up for failure. It's not a personal failure, and that's the title of this particular video. That was not a personal failure. That was a systems failure. And in this country, for decades, we have been responding to a chronic illness that 1 in 7 of us will experience in our lifetime with systems that are designed for discipline, or systems that are designed for an infection. And even for those inadequate and inappropriate services, only 1 in 10 people actually access them. We have a problem in this country around access to appropriate care, and it is because of the stigma surrounding substance use disorder. I strongly encourage you to watch this video. If you want to subscribe to my YouTube channel, that'd be pretty awesome too. I have 49 subscribers. If I get 50, I think I might get new bells and whistles. I'm not sure. Right on? Okay. Underpinning this concept of recovery-oriented systems of care is this business called recovery management. Recovery management. So if we're not going to respond to addiction with a brief event meant to cure it, or with a period of punishment meant to beat it out of us, then what do we do? Recovery management is a microsystem organizing philosophy. It organizes addiction treatment and recovery supports to enhance pre-recovery. Recovery priming, we call it. So how do we somehow get out into the community and make this a space where people know what recovery is and know that substance use disorder is a very prevalent thing, and know that it's okay to come and ask for help, and it's okay and you know where to ask for help. Recovery priming. And we accomplish this through a number of strategies that I'm going to talk to you about in just a second. Then recovery initiation and stabilization. Where do folks go for help? Where? Is there one place they go, or is there no wrong door? And I'm going to talk to you about that in a minute. And recovery stabilization, recovery initiation, where do we walk through the door of recovery? And then comes long-term recovery maintenance. So how do we sustain, if it's an event or a transformative moment in one's life or a simple resolution, I'm not going to do alcohol and drugs anymore, how do we as a society and as systems of care help to support that decision and set them up for success? There's a design for that. And recovery community centers are at the center of it. And then since addiction recovery means more than just putting the plug in the jug or stopping using drugs, that it actually means thriving in recovery. We go about trying to enhance the quality of personal and family life. This is a very exciting time to be addressing the overdose crisis. This is an exciting time to be addressing the prevalence, the morbidity of substance use disorder, because now we understand that it's not a moral, self-inflicted wound of the weak-willed. We understand that it's not a quick remedy, that it is a long-term remedy that requires all systems to come together in an unsiloed fashion. And now we understand that folks, the final destination, if one chooses for recovery, is that of full citizenship. You know, no longer defined by the pathology, no longer defined by the process of recovery. I'm a husband, father, grandfather, social worker, war veteran, North Carolinian, Tar Heel. I am a three-dimensional human being with hopes and dreams and goals, and I'm grabbing every brass ring I can possibly find. And I'm also a person with deep, deep pain and drive after losing multiple family members to addiction and mental disorders as a result of the fractured systems that we are now working within. Very exciting. So next is, right on. Next is recovery priming. So we need to engage in anti-stigma campaigns. We need to address stigma. We need to do outreach to folks. It's not a matter of waiting for them to come to us anymore. It's a matter of going where they are. We have recovery presence in the communities, like this particular recovery community center here, like people hollering about their recovery status in communities, raising recovery visibility, and then terminology. And our hosts are on top of that as well. They're down with the accurate and non-stigmatizing language. They understand the role that language plays in propagating prejudice against a group of individuals and propping up systems of discrimination that continue to exist. So we change our language when we're talking about people who use drugs and people experiencing substance use disorder and people in recovery. And the next slide, I have some splendid suggestions for you as well. This is some old school language that we no longer use. Substance abuse. Now, this is tied into a number of federal agencies and organizations, but there is a concerted effort that has made appreciable progress to change these names, to eradicate the term abuse, because we have robust data showing there is a terrible negative valence associated with this term. And I could share some amazing research with you where just when I think about an individual I'm working with, if I'm thinking about Donald McDonald experiencing a substance use disorder, I am more compelled to respond to him therapeutically with all the resources at my disposal. But if in my mind I'm thinking Donald McDonald, substance abuser on my caseload, my brain gets hijacked by that word, and we've strong data showing from a sample of over 700 people in the helping space that with statistical significance, when they perceive a potential person that they're going to help through that lens as a substance abuser, they are more inclined to respond with punitive responses and think that this person is a danger to society. If you don't think that our brains can get hijacked by language, you haven't been paying attention. Because at the root of any powerful movement to marginalize human beings and commit atrocities against these human beings, language is at the center of it. Pejorative language, words we should never use in public. And in this space, pejorative language is junkie or crackhead. If you're using this in any of the recovery-oriented system of care, stop. You're not to use that language in front of your children. You're not to use that language in your systems of care. You should be embarrassed to use that language. I've often been described as a former addict when I get into the newspaper or on TV, which is awesome. Former addict Donald McDonald. Every time I'm like, man. But I prefer to be called a person in recovery. And there's a number of other suggestions on here for you. People experiencing a substance use disorder, people experiencing addiction, a person in recovery. The term substance abuse and the term relapse, we discover, have its roots in the temperance movement, a moral, religious movement, but somehow they've made their way into the clinical space. So words that Carrie Nation was using, carrying around her hatchet, trying to save mankind from demon alcohol, somehow our physician is using them in his office today. Are you a substance abuser, and have you experienced a relapse? Have you relapsed? Did you pee dirty? We got to change the language that we're using, and this will make an amazing progress for us. Next slide. So this business of recovery initiation, we have to embrace the concept of no wrong door. We have to meet people where they are. We have to understand that motivation is a shared responsibility. Prior to this, we've been saying to people, when you're ready to come get what I got, I'll give it to you. And I did that as a provider of services. I had a very specific treatment modality that I gave to folks, and it was only if they came to me and if that's what they wanted and were willing to do. And we can't do that anymore. Motivation is a shared responsibility, and motivation is no longer a requirement to engage in services. We have to meet people where they are. We have to engage in harm reduction outreach. And I must say it right here. The intersection of harm reduction and recovery, it's inseparable. It's inseparable. If I'm picking and choosing whom I am going to help and what resources I am going to lend them, I'm cherry picking my human beings, and I'm trying to make my job easier. Learn everything you can about harm reduction. Learn everything that you can about the role trauma and disconnection play in substance use disorder. We've got the new CDC statistics out right now. We're in the middle of an overdose crisis, 93,000 overdoses, right? This is a mortality crisis of epidemic proportions, the likes of which we have never seen. If we're not addressing mortality in our approaches to trying to promote recovery, we're not doing our full job. This is a graphic that we created in North Carolina to help illustrate what we mean by recovery initiation, no wrong door. There's lots of stuff on there. There's inpatient, outpatient, social detox, medical detox, law enforcement assisted diversion, drug courts, mutual aid meetings. There's all kinds of different entry points that you can see on there. And then we transition into recovery maintenance or recovery management, or we come to recovery community centers to find some peer-based engagement with folks, some supports, where we go to collegiate recovery programs if we're going off to college, where we go to recovery high schools, recovery supportive housing, transportation, a job. So many people face obstacles to this place. And then what we want to do is we want to get to the center, the inner circle. The inner circle is this business I'm going to share with you soon about this enhanced quality of life. What is the return on investment beyond the piles of money that we save by responding appropriately to addiction? The inner circle, thriving in recovery. This is where I live, but I got here through dumb luck and chance. And then recovery, next slide, recovery maintenance. Folks who provide services, ought to stay connected, ought to support individual participants for up to 5 years. Not this 1 year check-in, but up to 5 years. What's right with you? What's going on? And a return to use ought not be the sole measure of failure. It is how short was that return to use, and how quick was their return to recovery pathway, and why did they experience a return to use? What social factors of wellness can we use or help them to access? The use of peers is something that everybody should be engaged in. And to really drive this concept home, we picked up this from the white bison well-brighting movement, this indigenous American concept of treating the soil for a healing forest. When previously our concept was taking a sick and dying tree out of soil that was non-nutritive, that was hostile, putting them into a nursery, singing to them, bringing them back to robust health, talking to them, and now you got right, and then sticking them back in the same environment, and then we're at a loss as to why our efforts weren't successful. So I love how Don and Kateri Koyas and the White Bison movement teach us through figurative language, and this concept of treating the soil and the healing forest drove home to me an understanding of recovery-oriented systems of care, of community-based recovery management, of addressing social factors of wellness. All right, what is a recovery community organization? We have one right here. We're sitting in one right now. And the definition that I've thrown up there, you read for yourself, written by Bill White. But what's important to know about an RCO, a recovery community organization, is that it is it's independent, nonprofit. It is led, founded, and governed by communities of recovery, people in recovery, family members, and allies. It is authentic. And it is designed to support long-term recovery, whether it is through advocacy and education, or if you're slightly more daring, you get to open up brick and mortar and engaged in direct community-based, peer-based recovery support services. And next slide, the hub, check it out. Community Recovery, Palm Beach County, the services that they are engaged in address the instrumental needs that are experienced by people, that address the barriers that they face. Check it out. I'm pretty super excited about being here and learning more about this community. And on the next slide, a little bit of self-aggrandizing is when I helped start a recovery community organization in North Carolina. This was the definition that I wrote, all right? And this was based out of, once again, some direction from SAMHSA. We've received some great guidance from SAMHSA. A critical recovery nutrient for any community is a safe and supportive recovery environment that offers a variety of recovery supports. A recovery community center is a place free from stigma that offers peer recovery support to the entire recovery community, regardless of pathway. Types of support fall into 4 categories: emotional, informational, instrumental, and affiliational. And that means, and this is what we did, we have space to provide everything from recovery coaching and to peer-led groups to job readiness training, professional education, help accessing social services and transportation, to ping pong tournaments and cookouts. That was exciting times, and I kind of miss it, and I don't know if anyone out there, anyway, I don't want another job right now, I'm happy. And enhancing quality of life is this business of folks thriving in recovery, of becoming full citizens. And often the barrier to that is stigma-driven as well. I had access to treatment. When I got to that jumping off point nearly 17 years ago, and my wife says, "I've about had it with you," I said, "I want to try one more time." And I had immediate access to evidence-based, co-occurring disorders, trauma-informed inpatient hospitalization, right then and there. And then when I transitioned out, they stepped me down to outpatient services. They connected me with communities of recovery. I had a very diverse community of recovery to choose from because I lived in an urban space. And then when I discovered that I wanted more, that I wanted to come get me some more, I had no criminal justice system entanglements. And many of us who have experienced this chronic illness that 1 in 7 of us do entangle with the CJ system. We experience felonies, and I was able to get a student loan, too many student loans. I was able to study counseling in community college while I worked as a security guard in an opioid treatment program. I was able to get student loans to go off to social work school, UNC Chapel Hill School of Social Work, to become a licensed therapist. And then when I went out to get jobs that did criminal background checks, they found nothing. Squeaky clean. What? But that's what I had, and that's what everybody deserves. So to enhance quality of life, we need to reduce these barriers. Second chance hiring, ban the box legislation, and addressing the stigma surrounding substance use disorder. And our stories have power. I'm out of time. Q&A. Okay. Well, I'm so sorry. It's time for Q&A. This is where I would have told a lot more about my story and a lot more about the return on investment. So do we have any questions right now from the audience or from our digital participants? And this is the first in the series, so they're ironing out all the bugs, and one of the bugs is Donald McDonald. Am I bugging you? Yes, sir.
Quick question about measuring of wellness, overall wellness. Could you speak a little bit about Recovery Capital and its role in allowing us, finally to get to a place of, measuring outcomes and wellness?
Absolutely. Asked about Recovery Capital, and I'm so glad that this got brought up. And this is present on your state's website, and Hanley's savvy to this concept of Recovery Capital. Briefly, just the internal and external resources that an individual can call upon to succeed, to sustain wellness, to become who they want to become. I had these things. Part of my Recovery Capital was I had a loving family at home. I was returning from treatment to a wife who was educated about addiction and provided a recovery supportive environment for me. I had recovery supportive employment, a boss that said, I'll hold your chair for you. I see you're going through some stuff. Come back and get you some when you're ready. I had health insurance. I had friends that supported my recovery lifestyle. I had a fair amount of insight as well, these internal resources that we can call upon. I had a degree of insight, and I had a degree of resilience that had helped me survive while I was out there living with addiction. And there is a Recovery Capital Index. So when we engage with folks, and I strongly encourage recovery community centers to do this, and I know that All Sober is going to do it as well, we're going to measure the presence or absence of recovery capital when we first engage with folks. What's the quality of your relationships with people? Are you addressing your mental disorders? And I'm drawing a blank on a number of them, but then we get to ask again. And one exciting survey that that I have included in the resources that will be available to you is we knew very little about recovery as an expectation in the past. It was more a concept of remission and disappear off of the radar. And in a call for recovery-focused research, Faces and Voices of Recovery, in partnership with the researcher Alexandra Laudet, conducted the Life in Recovery Survey. And this Life in Recovery Survey was a rather splendid discovery that we made. And I'm trying to pull up some of the findings right now. We discovered that the key findings involve dramatic improvements of all areas of life: health, better financial and family life, higher civic engagement, dramatic decreases in public health and safety risks, significant increases in employment and work. Specifically, when comparing them to a life in addiction, these results showed folks were paying their bills on time, paying back personal debt increased by 50%. 50% more people were paying their taxes in recovery. Planning for the future increased. Domestic violence decreased. Participation in families increased by 50%. Volunteering in the community increased threefold. Voting increases significantly. May not be good news for everybody, but I see that as a profound return on investment myself. And the percentage of uninsured people decreased by half. Reports of untreated emotional mental health problems decreased more than fourfold. Involvement in illegal acts and involvement with the CJ system decreased about tenfold. Steady employment increased more than 50%. Twice as many people furthered their education or training. Twice as many people started their own business. These are the returns on investments. This is evidence of the garnering and the increase of recovery capital in one's life. And we don't just stumble into this. Folks achieve this through communities of recovery, through deliberate recovery-oriented supports in their community. I did not achieve this sense of wellness that I had because I wanted it more than my fellows or because I'm morally superior to my fellows. I achieved this level of wellness that you see before you. And people in my state, they like to celebrate my recovery, man. I've taken so many pictures with legislators and policymakers. And I like to tell them on the down low afterwards, you cannot celebrate my recovery unless you completely comprehend how I got well. And I got well through what I described to you. And so North Carolina may want to consider expanding some things and stuff.
Yeah, thanks for sharing all that, Donald. I'm a little bit more curious on your personal story. Mind sharing like a Cliff Notes version of your story with us?
Yeah, I mean, absolutely. I began using, I'm sorry. Yeah, wow, let's start at the beginning. I was born into poverty. I was born into poverty. I was born into a trauma environment, and we understand now the role that adverse childhood experiences play in vulnerability for substance use disorder. I was born into family history of mental and substance use disorders. I was born with all of these risk factors coming at me. And so, but prevention wasn't really a super awesome thing back in the early days that it is now, and they didn't really identify that I was a person at risk. So around middle school, I started experimenting with tobacco and alcohol, and I felt whole. I felt connected to my fellows. I felt a sense of joy that I had never experienced. It was a good thing to me. And as I moved further in my career, I began experimenting more with cannabis and alcohol and stimulants. And what I later learned is that I was experiencing mental disorders. I was self-medicating my mental disorders. And I want to share some data with you, actually. my story is kind of important as a case study. The estimated genetic influence for substance use disorder is around 50%. So right there, I was born behind the 8 ball. And data vary in its intensity, but most folks agree that about 2/3 of people who are experiencing addiction also have significant ACEs. Childhood trauma, family history of substance use disorder. Right now, we've identified young people who may be vulnerable. As I move forward, the fact that that I initiated use at such a young age increased my vulnerability hugely. And what we know now is that the percentage of people who experienced substance use disorder who initiated use before they were 18 is over 90%. So as far as risk factors go, this is one of the ones that is most prevalent. Something happens that increases vulnerability to young developing brains when they discover the joys of alcohol and other drugs as a shortcut to connection, as a shortcut to joy, as a shortcut to safety and a sense of wellness and a sense of self-identity. And there are many things that we don't learn as we grow up. You really need to check out the disordered learning theory of substance use disorder, Maya Salavat's The Unbroken Brain. It'll change your life. And this really resonated with me because as I was a young person who was self-medicating much of the trauma that I was experiencing and the emerging mental disorders, and I found solace in these drugs, there were many things that I was not learning. I wasn't learning how to a positive self-identity. I wasn't learning how to console myself, how to experience joy and delayed gratification, all these lessons we learn as we grow up. And then I get sober when I'm 37 and I'm expected to be, a fully, awesome adult. And I had a lot of lessons to learn. Yeah. And so then I move into high school and I'm seriously self-medicating a lot of mental disorders at this problem, what I later learned to be recalcitrant bipolar 1 disorder. When I look back on the drugs that I was choosing at any given time, I was really in the process of moderating mood and balming emotional pain. So then I joined the Navy, and I got to be I joined Naval Intelligence because they thought I was a real smart dude. And they really freaked out my friends back in the rural North Carolina when the FBI started showing up, doing the background investigation, asking about Donald McDonald. Is this Donald McDonald a good dude? And they're like, oh, yeah, he's great, And but the way the Navy was at the time, cannabis, and you still can't in the military, use illicit drugs. But at the time, in the 80s, it was a very robust drinking culture. So I began drinking heavily. And it was, this also speaks to prevention, some strong work that Hanley is engaged in. Culture matters, normative behaviors matter. In the 80s Navy, I was celebrated for my capacity to drink whiskey like a Western North Carolinian. But that's not sustainable. Eventually, it doesn't entertain people as much as it ought to. And so they gave me a treatment event in the Navy. And I served honorably for years. I served honorably in the Navy for over 6 years. I experienced some trauma. I experienced a divorce. I experienced dislocation and disconnection. I got removed from my culture of recovery in southern Florida, which was awesome, and sent to an isolated duty station in the middle of the Indian Ocean, where once again the culture was to very much celebrate alcohol use and other debaucherous behaviors. And I held on I held on, and then I experienced a heck of a return to use. And while I got an honorable discharge from the United States Navy, they did ask me to go ahead and head on back home to North Carolina and not darken their door again. And once again, I showed you the data from the McClellan study. We need to come to expect that folks, just as there's vulnerabilities and risk factors involved with getting addiction or living with a substance use disorder, there's very predictable risk factors involved with having a return to use or recurrence of symptoms. And that is what I experienced. So I had a return to use, and I came home, and then I was in and out of wellness and for 12 years. I did really well at times. I did very poorly at times. I met the love of my life. I had 4 amazing children. I went to school to become a teacher, and that didn't work out. And then eventually I came to that jumping off point that I had described earlier. After many treatment events, this one more time. And the real game changer for this treatment event is that they addressed my co-occurring mental disorders. This was an evidence-based treatment center that had everyone from a psychiatrist to regulate my meds, to peer support who could connect with me on that level that only peer support can connect with, and that they understood I needed to transition into community-based services. And I ended up 13 years into my recovery. I got the job as the executive director of the NADAC affiliate in North Carolina, Addiction Professionals of North Carolina. And I go to my first board meeting at the first conference that we organized after they hired me. And I'm sitting next to this fella, and I recognize his face. And I finally figure out who he is. And I said, dude, 13 years ago, you were my detox counselor. I'm your new executive director. It's nice to meet you. That's a poignant moment. I have a wonderful picture of me offering him an award at the next conference for the art of counseling. And so my story is one where I had just immediate access to that which I deserved, and robust recovery supports, not in a separate community, inside my own non-pathologized community. I was surrounded by support. And then when the internalized stigma started to melt away, and I understood that it wasn't a moral failing, that I had a chronic illness, and then I remembered that drive I had to make this world a better place, I was able to come and get me anything that I wanted if I was willing to put in my fair share of hard work. And that's what it's all about, is we put a little bit too much burden on people experiencing addiction to do more than their fair share. And it's a shared burden among all systems of care: addiction, treatment, recovery support services, and then all of the other systems that are involved with a recovery-oriented approach: housing and transportation and healthcare and opportunities for employment. And that's my secret to success.
Thank you so much for sharing, Mr. McDonald. We do have a few questions from the chat online, and just for the sake of time, this has been so informative. We really enjoyed it. I'm going to go ahead and just ask 2 of the questions we've received.
Okay.
So first, our participant, Sarah, would like to know, do you have recommendations on materials that she could reference to help prove medical necessity?
To help prove medical necessity? Wow. I'm really, I'm not in a position to really answer that question. Yeah. Yeah.
Okay. Well, thank you.
Yeah.
Our next question from Laura.
I'm sorry. It's out of my wheelhouse. Yeah.
Understandable. And we're going to see if we can find a resource for Sarah.
Absolutely. We will answer your question.
But our next question from Laura, she says, regarding stigma, are the words addiction and alcoholism okay, or is that language also stigmatizing?
Well, let me tell you, fortunately, this drive to embrace accurate and non-stigmatizing language is data-driven. It's research-based. So researchers, check out the Recovery Research Institute, recoveryanswers.org. It is a repository for much of the relevant research associated with the negative impact of language. Some we know, like substance abuse and labels like addict, and other labels like clean. We've measured the negative valence associated with those. Some we need to keep an eye on. You know, I'm one who hasn't abandoned the word addiction. I still use it, but I'm keeping an eye on it. The emerging data on the negative valence associated with it, with its root in the label addict. Alcoholism, it's a very familiar word. It is what we called alcohol use disorder previously. I don't know of negative data, and what it is language that we need to change is one that creates a negative public perception or a negative internal reaction to vulnerable people that we've committed ourselves to help or to set up for success. And so that there should not be a resistance to this move for accurate, non-stigmatizing language, because honestly, it is the simplest thing that we can do to dismantle discriminatory barriers to our loved ones to find freedom and wellness. So I hope that answers the question. I don't have a definitive answer on those, but there's language to keep an eye on. I would go to the recoveryanswers.org. And also, in a call for unified behavioral health language, they created a helpful resource called the Addictionary, where if there's a behavioral health term that you're curious about, whether it's alcoholism, punch it in, and it'll come up and it will define what it is, and there'll be a flag there if there's concern, and the flag will be definitive in that, oh yeah, we've got smoking gun evidence on this one, don't say it anymore, or we're keeping an eye on this and you might want to reconsider. So very helpful resource, Addictionary. Yeah.
Well, thank you so much for taking time to answer our questions. Do we have any additional comments or questions from the audience?
I have one more. I appreciate your work with recovery initiation. I struggle with the no wrong door. You're a clinician, and often initiation is at treatment, and we do have gold standard for patient placement criteria, but often we land in the door we don't belong in. So could you really talk about the use of patient placement criteria? Because we automatically think residential is the cure.
Yeah.
Which is, at least we all know, is not true.
Not true.
You could just address
Absolutely.
that misunderstanding around treatment.
Yeah. Understood, yes. That's a splendid observation. This speaks to recovery capital, which we also mentioned before. When you're considering what level of care or level of intervention or support that an individual needs, you have to consider a number of things. The problem severity, the problem complexity, and the presence or absence of recovery capital. And it takes a trained individual to have a comprehensive clinical assessment with individuals to discover exactly where they are. And the American Society of Addiction Medicine has come up with very clear criteria for what level of care may be appropriate for folk. And it's not always inpatient hospitalization. In my instance, I had a high problem severity. I started using drugs at a very young age. I had high problem complexity with co-occurring mental disorders and trauma. My recovery capital was pretty high, so they might have been able to stick me in outpatient, and I may have done well. I'm grateful I got the inpatient event, but inpatient hospitalization and residential is not always the right level of care. There are varying levels of care, up to and including simply addressing folks' social factors of wellness. someone to listen to them, a recovery coach to listen to them, talk about what they're going through, a recovery community center to help address some of their instrumental needs, whether it's a bus pass or some food. And then before you know it, and housing's a huge factor. Addressing housing needs is a tremendous thing. No wrong door as a concept is no matter what door you walk in, folks in that particular sector may know what to do or where to send you. And oftentimes in the behavioral health space, it can be a mystery. And Google it or ask a friend who might know. And so we need to get all these sectors as savvy as possible to what supports and care is immediately available to the people that they encounter. We need to address the stigma in these sectors as well, so folks just aren't turned away, that they are given the help that they deserve at the appropriate level that will most benefit them and not displace them. So that's what I mean, and that's what I think a lot of folks mean by no wrong door, that if I walk into my primary care physician and she discovers that my issue isn't acute pain, I may actually have a more complex issue, that is a door I've walked in and I will seamlessly be connected to a higher level of appropriate care. And this can happen in justice systems, it can happen in family systems, it can happen in social services systems as well. Something to check out is SBIRT, screening, brief intervention, and referral to treatment. Address the stigma. RCOs have a tremendous capacity to address stigma in their communities through public education, through recovery visibility, providing opportunities for people to tell their stories and get known in the community, and for utilizing accurate and non-stigmatizing language in everything that they do. So, and the last evidence-based anti-stigma strategy I'm going to talk to you about very briefly is that of mobilizing. Advocacy and activism is evidence-based anti-stigma work. So education around what causes substance use disorder, contact strategy through storytelling, accurate non-stigmatizing language, and mobilizing your community to activate when they discover that people may be discriminated against. It's awesome work, and it all gets done in an RCO. Yep.
Well, thank you so much,
Thank you.
Mr. McDonald.
Thank you.
So thank you everyone who has attended tonight, those virtually and those here in person. We would just like to remind you all that this is only the first session in our 7-part series. Those who attend all 7 parts of the series will receive a virtual Recovery Leader Certificate. So please be sure to check your emails. Tonight we will be sending out a brief survey, and it will have a link with an opportunity for you to ask additional questions regarding the series. Be sure to join us next week as we focus on the role of the family in recovery. You can register online at hanleyfoundation.org. We'd like to take this time to thank our supporters and our community partners. Once again, thank you, Palm Beach County, and special thank you to the Hub. And for those of you viewing at home, thank you, and thank you to the members of our recovery community. Have a wonderful evening.